Thank you so much for joining us tonight. It's 7:32. I suppose we should get started with this evening's program. And I'm not sure if I'm supposed to thank the folks at PRMS for providing sponsorship for this function, but if I am, thank you so much. We're glad that you're all here tonight. Please help me welcome my very special guest, Ilana Kiefer. Ms. Kiefer is with the New York Academy of Medicine, and she is the acting director for the Center for Healthy Aging at the New York Academy of Medicine. And recently, our governor, Kathy Hochul, signed a new mandate about a master plan for aging in the state of New York. And so I know Alana is very involved in these endeavors along with everyone else in her staff at the New York Academy of Medicine. And so I'm really delighted that she agreed to speak with us tonight about what are some of the opportunities and challenges of healthy aging in the city of New York. Thank you so much, Alana.
Yeah, you're welcome. Thank you. So just one resume correction. I'm finally the director of the Center for Healthy Aging. They finally gave me the promotion a few months ago. Yes. So yes, thank you. So nice to see you. Thank you for having me. I am here to talk about a few different things, but primarily the master plan for aging in New York State, which is actually now kind of nationally being shifted from the word master to multi-sector. So we're still calling it the MPA, but it's generally now being called the multi-sector plan for aging. And just by a show of hands of those whose cameras are on, have any of you heard of that term, the master plan for aging, the MPA, or the multi-sector plan for aging? No. Okay, great. So this is all new. Wonderful. So I'm going to share my screen and tell you a little bit about the work that we do at the New York Academy of Medicine. Oh, before I do that, 1 second. My AirPod fell out. Before I do that, who here has heard of the New York Academy of Medicine and or been in our building? A few more people. All right, good. So we're located in East Harlem and right on Fifth Ave. And we have a number, about almost 2,000 fellows that are part of NYCPS, including a psychiatry section, in case any of you are affiliated with NYCPS more formally. And one of the research centers that we have is the Center for Healthy Aging, where I am. So let me now share my screen, and we'll do that. Okay, I don't want to lose you, so let me bring you guys back up. 1 second. Okay. Hold on 1 second. You all, okay. Okay, you all can see my screen? Yes? Okay, great. So let's get right to it. Oh, there we go. So the New York Academy of Medicine, some of you may know, our mission is to drive progress towards improved health through attaining health equity. Health equity is the theme kind of throughout all of the work that we do at the New York Academy of Medicine. We have 3 different research centers, and the one that I direct is the Center for Healthy Aging, which, not surprisingly, where we work to improve the health and well-being of both today and tomorrow's aging populations. And you all work in geriatric psychiatry, so you probably know there are different ways. There might be a formal way to define geriatrics. We typically use 65 and older, but for some of our projects, it's actually 55 and older. And I know that the DFTA, or the NYC Aging Commissioner, is really trying to lower the age for services throughout New York City to 60. So there's a lot of different ways of defining it. So I just wanted to briefly touch on a number of different projects that we work on at the New York Academy of Medicine, specifically at the Center for Healthy Aging, that are not directly related to the multi-sector plan for aging, just to kind of ground you in some of the work that we do. If there's any kind of connections that you might have or interests you can have, I'm happy to talk about that. And we have some resources available that we're always happy to share with professionals in the field. So the first one is we actually have a state contract with the New York State Office of Mental Health to serve as the Geriatric Technical Assistance Center. Some of you might know there's a 5-year demonstration project happening right now in the state with 4 mental health agencies in New York City, 1 in Nassau County and 1 in Orange County. that are really trying to address any behavioral health, aging, and or substance use needs of vulnerable adults 55 and older. And so we're serving as the technical assistance center for all of those 6 projects to organize webinars, to share resources and best practices and the like. So I'm happy to talk more about that at any point. We also have a federal grant that's really looking at minority aging services and bringing together different national organizations that focus on minority populations within the aging and caregiving community. So for example, the National Center and Caucus on Black Aging, the National Indian Council on Aging, SAGE for LGBT older adults, the National Asian Pacific Center on Aging, and MHP Salud, which focuses on the Hispanic older adult population. So we bring those organizations together on a regular basis, and we have a resource library. So if you have patients that you work with that come from minority aging populations, which you probably do, we have an online resource library divided by categories related to aging and caregiving that are all geared towards different minority aging populations. We also have at NYCPS, we have about 80 fellows who are physicians, social workers, nurses, and the like, who are in our section on healthy aging, and psychiatrists are included in that list. And we do a lot of work on workforce development. You all probably know that there's a lot of work to be done, both in terms of training and also in terms of recruitment and retention in many different aspects of aging services, long-term care, hospitals, and the like. And then we do work on this multi-sector plan for aging that I will spend most of tonight chatting with you about and getting your ideas on. We were funded by the John A. Hartford Foundation back in the summer to create a summit. So I'll explain in a moment, but the multi-sector plan for aging the executive order from Governor Hochul had not yet been issued, but we knew it was happening. And so we wanted to bring together stakeholders across the state to plan what we could and to convene together so that we could hit the ground running when the executive order was issued. So that is where we are. And let me go to the next slide. Oh, let me stop actually, and please feel free to interrupt me at any point. Are there any questions or comments so far about what I said? All right, I hear silence. So I'm going to move on to the next slide. Okay, so the first ever master plan for aging happened all the way across the country in California. And I think they came out with their plan in 2020. I might be mistaken, somewhere around there. Yes, in 2020. So California was first ahead of the game. And, California and New York have a kind of healthy competition for being large and very diverse states, obviously very different states in many ways. And they realized we have a lot of older people in our state that we haven't really been thinking about or planning for. So you can see here, this is just a press release from the plan that they created. And it's a 10-year plan for the state. And it's developed by many different stakeholders to really think about the many different aspects of aging that will obviously impact really people of all ages in the state. They have a very impressive website. I can put it in the chat when I have a moment. And you can really see their plan in full. They're tracking data about the plan every minute. It's quite robust, it's quite organized, and they really are the leader in this work. And once Governor Newsom issued the executive order and they started working on the plan, all these other states said, hey, we have a lot of older people in our state too. We want a similar plan for our state, including New York. So New York issued an executive order as well. So you can see here, this is actually a little bit before, but even when Governor Hochul issued the executive state budget, this was actually already a year ago. She clued us into the fact that there would be an executive order for the state of New York by ensuring in the budget that there was money set aside for this. And then just in November of 2022, the executive order was actually issued. And just to give you a little flavor, this is actually from a few months ago, so this might be more updated, but this is a map of different states around the country that are in different stages of development of their own multi-sector or master plan for aging. So I know it's kind of small, but I can tell you that if a state is in kind of that pinkish red, that salmon color, that means that some type of the master plan for aging has already been developed and or implemented. So that's California, Colorado, Texas, Minnesota, and Massachusetts. Any state that has the kind of blue lines, kind of the hatched lines, the diagonal lines, they have some elements of some type of plan. The states that are kind of green with the little dots are there's a plan under development, which includes New York and Vermont. And then anything that's gray at the moment, again, when this was taken, which was now several months ago, no current plans. However, you might also see there's little yellow stars across the map. There's another nonprofit organization called the Center for Healthcare Strategies. They're leading a multi-state learning collaborative for states that are saying, hey, we do want a plan. We're not quite sure how to go about it. Can you help us? And so this learning collaborative is bringing together a number of different states, and they meet on a regular basis to do just that. Any questions or comments so far?
You know, I was wondering about the states that have a star.
Yeah.
And where are they on this type of development? Where are they on the spectrum?
So they're in, and I think the collaborative is still going on. So it's states like Oregon, North Dakota, Colorado, Minnesota, Vermont, Tennessee, and the like. There's 10 states. So they're all meeting together and with outside experts to really figure out how do we go about essentially getting our state on board, which means usually getting our governor on board to issue some type of directive or executive order to create a plan, and what are the pieces that we need in order to develop this plan.
Thank you.
Sure. All right, let's go to the next slide. So there's a lot of information on this slide. I promise you don't need to memorize it, but I just wanted to give you a general sense of who's on the committee, because I don't know who all of you are, but I assume most, if not all of you, are affiliated with a variety of healthcare organizations. So some of these might look familiar to you. So the executive order was issued in November, and they hit the ground running. The planning process, which will take between 1.5 years and 2 years to develop this plan, is being chaired by the Department of Health, the New York State Department of Health, but it's also being kind of co-chaired by the New York State Office for the Aging. So those are the two state offices that are leading this effort. And there are many other state agencies like the Office for Mental Health and others that are part of this planning process on the state agency level. In addition, all of these different organizations you see listed here are on what's called the Stakeholder Advisory Committee. You will see that the New York Academy of Medicine is not on that committee. So unfortunately, I can't tell you too much about this, but we have a lot of kind of colleagues that are involved in the actual planning process. And NYCPS is kind of in a few different ways. I'm not going to go into details, but we are still able to impact this plan in a few different ways. But just to kind of get a sense of the different organizations, you can kind of see they really want a variety of stakeholders, and luckily also some kind of non-traditional stakeholders to be involved in this plan. Okay, so I talked about this executive order that was issued in New York State. I'm not going to read the whole thing, but I did want to point out a few key points that specifically relate to not necessarily directly psychiatry, but mental health and health in general. So I just wanted you to kind of be aware of them, and geriatrics. So the first one, in the executive order, it says, New York State has the 4th largest population of older adults in the US. 16% of the state is 65 and older. That's quite high. That's a very large number. I don't know if California might be number 1 or Florida actually, but we have a lot of older adults in our state. Number 2, New York has been a leader in advancing policies that address social determinants of health. There are many different ways that New York has done that, but it goes to show that we are ripe for this type of work. And again, this is all kind of like general quotes from the executive order. New York State needs to assure that our healthcare system is prepared to handle both the demands and the preferences for care. That's both outpatient care, inpatient care, everything in between. And we know as a state, especially in New York City, that hospitals and long-term care systems are understaffed, overpopulated, could probably, use a lot of support, and we're not ready to handle 16% of the population. And the healthcare system also includes home care, which obviously is the most kind of commonly used type of care. Public funding of long-term care through Medicare and Medicaid is, it's substantial and needs to support the broad goals of healthy aging. So, for example, needs to really support more preventative care rather than just treatment, for example, which, those payers, they do to some degree, but certainly could more so. Healthy aging, that doesn't just include the physical body, but also obviously mental health, housing, socialization, all of those different things. So that's one thing that this plan is going to really be looking at, are those more kind of, as it says here, broader goals of healthy aging, which obviously includes all different types of caregiving as well. Healthcare workforce issues must be addressed, along with ways to better support informal and family caregivers. So I think I hear on webinars, they quote, how many billions of dollars informal or unpaid or family caregivers essentially work taking care of older adults. And there is certainly not enough infrastructure or support in place for these caregivers. There's also the CDPAP program in New York State, Consumer Directed Personal Assistance Program, I think it stands for, where family members can actually be paid to care for their loved ones. And I think paid through Medicaid, I believe. It is quite underutilized. A lot of people don't know about it. People could be getting paid and they're not. So I'm hoping that this plan will kind of address that as well. And obviously the kind of workforce issues that I mentioned before are far and wide, and obviously the pandemic did not help the workforce issues. Issues regarding access to affordable and suitable housing, transportation, the choice and ability to age in place, mental health, that's why I bolded that for this group, social isolation, ageism, any opportunities for civic engagement and volunteering, for example, and also addressing and hopefully preventing elder abuse must be addressed in this plan in a comprehensive manner. So there are a number of social workers and leaders in the mental health community that are on a committee that I'm on related to the multi-sector plan for aging. So they were very happy to see that mental health was addressed at all, but felt like in the executive order, it didn't go quite far enough. So that's just one thing to kind of keep note of. Okay, any questions or comments about this particular slide? Or thoughts?
Yeah, yes. My name is Leslie. I lived in New York my whole life, but I've been on Maui. And if I ever have to move back to New York, I have a lot of problems. All over the country, the retirement communities have, tennis courts and golf courses and all that stuff and activities. And there's nothing quite like that I know of in the city. They're very expensive. The other thing is that I have doctors at Weill Cornell, which is one of your partners, as well as where I am on Maui. And I just had to get a new primary care doctor because the two that I had that were great are not, they retired or whatever, sick. And that was unbelievable. So there is, no matter, even if you have money, and that's not an issue, the access to care is an enormous problem.
Agreed. Totally agreed. Yep, definitely.
And my daughter lives in Brooklyn, and so I have to worry about safety on the subway.
I know. Yep. All right, I'm going to keep going. Thank you, though. So this is kind of the definition of a multi-sector plan for aging. You've probably picked up on a lot of this already, but it is a cross-sector and state-led strategic planning process and resource that can help states transform both the infrastructure and the coordination of services for the aging population, but really for, again, everybody. What's cool about it, and you can see it with the California plan, is that it's a living and breathing document. So they really, they came up with a plan, but they really are tracking it, making adjustments to it, and hopefully these other plans will do that as well. It's going to be about, typically a plan is for 10 years. It really enables state leadership, whether it's the governor, the state legislator, or the state legislator, to really kind of work with their state agencies and the committees to really map out what it is going to look like for older people to age in community. And to really, it really should, hopefully will put a heavy emphasis on aging with dignity for any type of older person and whatever type of programs they're accessing. And as you can see from the kind of multi-sectoral committee, it really does try to get a lot of input from many different types of people. You couldn't see in that stakeholder advisory committee, but they are recruiting retirees and others, older adults, and also people with disabilities, to really kind of understand from them, what do you want the state to look like over the next 10 years as you are aging in place? So, and this whole section was adapted from a toolkit that same organization, the Center for Healthcare Strategies, developed for states. Again, there's 50 states. Hopefully every state at some point will have this plan, and they can use this toolkit to help guide them. So let's talk a little bit more narrowly about the multi-sector plan for aging and geriatric psych. So this is the discussion portion of the evening, so I hope you will all participate. Now, again, I'm going to take some notes. As I said, I'm not on the official committee, but I do have lots of people I'm connected to that are. So I will definitely bring these points to those who have direct influence. But what do you think are some key points that the MPA needs to include to address both the psychiatric and mental and/or behavioral health needs of older adults?
It's a general and a specific question, if I may. How do you define healthy aging? And the next question may be too specific, but is there a way of measuring it? Because, for example, pick any intervention you want. Provision here of mental health professionals to serve the population. Suppose you set up a program and you have hired some people to do that. How do you measure whether that has had an effect on healthy aging, right? We would all, as mental health, I'll just stop there. How would you measure it? And how do you define healthy aging? And how would you measure it so as to know whether your intervention of any kind, or any service that you improve the workforce, how do you know that translates actually into healthier aging of a given population?
Yeah, I'd have to get back to you to give you a much more formal response. But initially, I will just say that I think we really think about healthy aging at NYCPS as the opportunity for people to grow older in the places they want, with the people they want, and in a way where they have agency to grow older. And the term we'd like to use now is aging in community. There's a term you probably heard, like aging in place. But I think we saw during the pandemic how important community is as all of us are living, and particularly older adults. So that's kind of my initial gut answer to your healthy aging question.
As far as getting back goes, how would we get in touch with you actually after all?
I'm going to give, I'll give you my contact information. Absolutely.
Okay.
And I think just briefly to your second question, I think in terms of metrics, I think it's hard. It's definitely hard to measure. I would say one measure is looking at hospitalization rates. It's looking at rates of falls. It's looking at, those are kind of two more concrete ways. And that's why I really like to stress prevention rather than treatment, are the kind of methods that we're implementing, reducing those numbers. So it's kind of more of an absence of hospitalizations, an absence of falls, for example. I think it's also, again, hard to measure, but measuring satisfaction or happiness or reduced depression, all these different mental health screenings that I'm learning about now with our state contract, the PHQ-9 and all those other ones that I can't really talk about because I'm not a mental health professional, but I know exist. Those are some ways, and I don't have an easy answer for you.
Thank you.
Sure. So now back to my question, what do you think are some key points that this plan needs to include? What are things that we need to really kind of address, which can really get to what you were just asking, to really be thinking, rather than just saying mental health, how do we narrow that a little bit more?
Well, I'll give you a kind of an example, but
Sure.
I'm just in serious mental illness, but in my career I was, we would say that one measure of improved mental health is ability to take care of one's physical health. So, for example, many people would say the greatest lab value that psychiatrists, mental health professionals could ever use to measure a person's mental health is the hemoglobin A1C. Because if you can manage your diabetes, you've probably got some things under control.
Yeah.
And having one thing under control enables you to help. Why does a person stay well? So if they enjoy their life, anyway, I'll stop.
I like that. Yep.
So it's anyway.
Thank you. I think I'd like to take a stab at this because it's a big problem that we have in our city, which is really appalling because New York City is so ahead in terms of providing care. It's really appalling the gaps we have in geriatric mental health care. And I think, and I don't speak for all my colleagues here tonight, but I do think that one of the problems we have is access to care in terms of not having enough providers that are qualified to deal with the complexities of an older population. But that's not, we can navigate that. We definitely have the resources to provide that kind of education to our current workforce. But I think the big problem too is that the fragmentation of care.
Yes.
And there is too fragmented. It's sort of like when as for children and adolescents, the system is a little more cohesive and a little more encompassing. And then as they become adults, then they go out into a world that is very complex and difficult to navigate. And as we get older, it becomes even more complex and more difficult to navigate because the avenues for the provider is so narrow. And then we're blessed in New York to have such a multicultural, multi-ethnic community. So we need providers that can navigate you in different languages for different folks for all over the world. Chinese, but also South Korean, a lot of different languages, Hispanic, a lot of different languages. Definitely. But I think that definitely access to care is a huge problem. And geriatric psychiatry is very unique because it's the intersection of in general medicine, neurology, and psychiatric care. And so then we have two populations here, the populations that have aged with serious mental illness, which we deem SMI, which is the population that I work with. And then we have another population that's been pretty stable and pretty successful throughout their lives, but now they're facing the challenges of aging. And they might need additional psychiatric and mental health support. And how do we navigate that kind of support for older folks to help, to age well? And so I think those are really some of the key points that I can think of off the top of my head.
Totally. And do you tend to work a lot with dementia?
Yes, I work.
Psychiatrists, is that right?
And we try to tease out what is dementia, what is delirium, what is, and what type, because you know, the DSM, we don't have the word dementia anymore in the DSM. It's
Really?
yeah, that's the
Oh,
DSM-5 completely changed. And at the same time, then we have our neurology colleagues, our neurologist colleagues who have a whole different terminology, but we're looking at minor neurocognitive disorders,
okay,
major neurocognitive disorders. Another big problem we have is we don't always have enough providers in neurology and memory disorders clinic to address the needs of this population.
yeah,
Whether, even if they have insurance, there are a lot of patients I have nowhere to send for neuropsych evals, MRIs. There's a long waiting list. The resources are exceedingly limited in a city that is pretty abundant and affluent. It's really appalling. So I think if we can make some headways in opening some channels of care and some avenues of care for our patients that are aging, that would go a long way.
absolutely. And I think also with SMI, people are aging at much younger ages. So, so aging there might be kind of the onset of aging issues. Like I know, as I said, the project that we're doing for the state is 55 plus. And so, and I know other people that work kind of with SMI in different settings, including in the like supportive housing setting, their version of older is 55 or even 50. So yes, it's just that there's, you know, a lot to consider here. I'm going to move on to the next question, but anyone can feel free to answer any of these. Who are the key stakeholders that need to be included in both the development and the implementation of this plan? Who might we not be thinking of? Like, for example, I don't actually know, is there a geriatric psychiatrist on the planning committee? I don't actually know, but I assume it would be helpful to have at least one, if not more, on there. Who else do we need would be helpful to be involved?
Older adults.
Yep, definitely. Definitely.
I think memory disorder groups that
Yep.
are,
Yep. One thing we haven't actually touched upon is medication. And, you know, really thinking about polypharmacy and thinking about meds in nursing homes. And, you know, that's a big one too.
Absolutely. Yes.
Yeah.
And we haven't touched upon subadequate housing or lack of housing.
Yes.
I have a patient that cannot walk. She lives on a 5th-story walk-up. So to see her children carry her down, there's no elevator, right? So carry her down and up, and she's on 3 CNS active medications. So talk about polypharmacy, and she's been on these medications for a long time.
Wow.
And she's just one example of many across the city and the boroughs that are really, because she's been in this apartment for a long time, she pays very little money, and it's very difficult for her to get an apartment on a low floor, and she probably won't, but it's not a sustainable situation. And many of our patients live in this kind of subadequate housing. And I'm not seeing a lot of momentum through the city to really address this issue.
I know.
As well as ADA bathrooms is a big gap in the city, a big gap. So I think maybe some kind of architect or contractor that works with ADA might be a good sounding board, if not part of the committee, but definitely in consultation with what are the plans for accessibility in the future.
And I would add to that occupational therapists who can do an assessment, you know, for an individual in their apartment and make suggestions such as, you know, making the bathroom more accessible, but even something just simple as just putting in a grab bar in the shower. You know, those small things can obviously make a big difference, especially when it comes to falls prevention. And there are some programs that provide OT assessments free of charge, but not enough. Anyone else?
The other thing that I know is a big gap here is home health services and 24/7 supports, round the clock supports. And I don't know how, if this plan is included to expand Medicaid to provide more home health aid supports at home, because all my patients want to age in place.
Yeah. Yeah.
I've never had a patient come to me and say,
Whoever dreams of living in a nursing home, right?
yes, can you help me place me in the most adequate, long-term care facility? I've never had that. And I don't
Right.
think I will, because we all want to age
Totally.
in the privacy of our homes, close to the people that we know and where we've been living for decades in the city.
Correct.
And I think that's not an unreasonable thing to ask for.
I agree.
Being near the end of life, right?
Yep, I totally agree.
Or not the end of life, but certainly the last stages of life.
Yep, definitely. How can this plan, you've touched on some of this, but how can this plan incorporate the workforce needs of the geriatric psychiatry profession?
Elena, I think if I please, I like other of my colleagues to interrupt me. I'm very passionate about this, so please, I like to hear what others have to say. But I think if you could work cooperatively with like a national organization like the American Association for Geriatric Psychiatry, which is always looking to recruit geriatric psychiatrists to the field.
Yeah,
I think that might be, or maybe the American Geriatric Society. Obviously, we also need geriatric internists, and yes, I think that might be a good way to build on synergies, because there's a lot of momentum behind this with a lot of the academic and the medical training environment to try to recruit more physicians and psychiatrists and other specialty providers into the fields of geriatric, whether it's geriatric medicine or geriatric psychiatry. So that might be a nice way to build up on the momentum, because it is very challenging. I think a lot of our international medical graduates that are interested in psychiatry are seeing a difficulty obtaining positions in fellowship training programs because they don't have the proper documentation, and that's all immigration. And I think if some leeway could be made in that area, that would be really very helpful, because we have a lot of talent that is leaving our state because they're interested, but they cannot get any major academic institution to train them because of these issues with visa and immigration. So that, I think, is something that is really worthwhile looking at.
Yep, totally. Other thoughts on this one? Okay.
I just
please.
You mentioned earlier that there are 3.5 million older people in New York of all who have all kinds of needs, and mental health issues. I'm from the old, trained too long ago, I guess, but we think in terms of health and illness. That's not, we're not talking about preventing or modifying illness as the goal of 3.5 million people to age in a healthy fashion. We're talking about things that enhance their, you mentioned this earlier, satisfaction, happiness, social connectedness. These are not typical, I think Dr. Diaz mentioned, not in the DSM-5.
Right.
So these aren't going to be covered by traditional systems of approaching illness. Right. So I'm trying to think of more broadly how one promotes status. I like your definition. Degree of satisfaction, happiness, social connectedness, management of general health, mobility. Those not from an illness perspective, but what kinds of lifestyle issues promote that kind of aging process.
Yep.
Leslie and I could probably give you a couple of examples. I'm 81. And I'm jogging 3 times a week, 3.5 miles, as is my wife, who is also 81. And so when I fall, I don't hurt myself if I fall. Yeah. I mean, that's the kind of thing we're extremely fortunate with health, but there's still issues around promoting healthy aging in people that aren't so fortunate, in any socioeconomically or health-wise, or in terms of social networks. I'm still trying to figure how we know that we're making a difference. If we had
Yeah.
5 times as many psychiatrists, would the population, however you define it, over 55 or whatever it is, 65, would they say that they are more satisfied and happy if we had 3 times the number of geriatric psychiatrists? I'm not sure.
Yeah, all good questions. And the only thing I will add is I don't think the plan ignores illness, but just wants to make sure that we're like talking about that plus those other things such as satisfaction
good,
and
good, thank
exercise.
you.
I think, you know, it's because it's really making sure that
Sure.
Medicaid and Medicare are really, you know, ensuring that they can cover basic needs and you know, aging related illnesses and others. But we're trying to just make sure that it's broad enough because there are so many different aspects. And I think that the pandemic in particular showed just how important the socialization is for, again, for all of us, and particularly for older adults, and how it's something that we don't often talk about or think about or didn't until COVID. And
Mhm.
yeah, I mean, I could go on for a long time about that, but yes, absolutely. And you run more than I do, so I'm extremely impressed that 3 miles 3 times a week. So wow, yeah.
I actually bump into Dr. Tucker now and then in Central Park jogging.
Really? Oh, lovely.
I don't think he recognizes me, but I recognize him.
Sure would now.
That's funny.
Next time I'll stop and say hello, but we're always running, so we're in a group, so I just don't really want to bother you, but I think it's wonderful. So Dr. Tucker, what do you think would make a difference for you? But for maybe, you don't have to speak personally, I don't mean to put you on the spot, but what do you think would make a difference if you had to maybe give some suggestions to your to someone about what would make a difference in New York City for you and your family about aging and being happy and aging well?
Speaker tonight. I've done plenty of geriatric psychiatrist as my last job. But anyway, it's a big question. I think it's wonderful that there's an organization that has a committee that's addressing this, because it's not in our standard curriculum or modalities really dealing with these things. I think various kinds of groups that bring people together. I think the Tai Chi, when you must have seen these, Dr. Diaz.
Yeah.
If you jog in Central Park, you can't go very far without seeing groups of people of, by the way, varying ages in these groups, doing Tai Chi somewhere. I look at them and you know, which is good for balance, for breathing, for camaraderie, because I actually think now I'm going to do what you did and say, somebody else interrupt me to stop this. But I think that when people feel they have control over some aspect of their lives that's important to them, I don't care what, they can visit their children, their grandchildren, let's say. Let's just say that. They like to be with their grandchildren. For them, healthy aging, if they can arrange to do that, deal with transportation and personalities and everything else, they then start to find that they have control over other things in their life. They start brushing their teeth more if they can see their grandchildren, because they don't want all their teeth to fall out. I mean, it's more like that rather than, you know, a dentist treating your cavity. You see what I mean? In other words, if there's something that you like, you'll start to organize your life and deal with health, housing, you know. By the way, people wouldn't think of Medicaid. I can imagine certain groups of people who wouldn't think of Medicaid as wanting to promote health, for example, but they could. And I worked in programs that had Medicaid and State Department of Health money to help people organize their lives so that they can take over their lives. People define these. That was a wonderful suggestion somebody made. Get some old people on your committee. You young, healthy people, you make us feel terrible because we're never going to look like that anymore. But really, people can tell you what they want. But often, if you wanted to introduce a modality that would do something, to me, rather than more psychiatrists, I would introduce some kind of an activity like Tai Chi. And the people that participate in that group, they're going to buy more useful clothes, or
Yep.
they'll eat better food, or they'll do whatever because they want to keep doing the Tai Chi, and they look around and they see somebody over there like you running in the park and say, you're doing, hey, wait a second, where'd you get those shoes? How far do you go? Those are the kind, and those become motivational. You see what I mean? It's not those help you motivation to keep doing things for yourself. And once you start feeling that, well, anyway, I've said enough.
But yes, I really like that and agree with it. We just have a couple minutes left, so I just want to raise this. We are all about health policy at NYCPS. So I was just curious if any of you have any thoughts about any city, state, or federal policies that need to be changed or improved upon to better serve the mental health needs of older adults.
What
I mean, there's
about
many,
private sector? What about charitable organizations and private sector help? Because this is Medicare and Medicaid aren't going to take this over.
Right. So you're saying that the private sector, meaning like corporations?
Yeah, or
Yep.
foundations mostly.
Foundations mostly, yeah.
Not for profit, yeah, foundations. Yeah.
But also, I believe that achieving parity for mental health care is going to go a long way.
Yeah.
That's
Yep.
certainly important. Absolutely.
Definitely.
I think
Absolutely.
definitely that's something that really needs to be.
And also continuing to destigmatize it too.
Absolutely. That will drive federal money, and that will drive Medicare money, and that will drive Medicaid money into this.
Yeah.
I think that would be very important, very useful.
Yep.
Use
I
of the
agree.
resources.
All right. Well, here's the last slide, and I can send these around. But this is you can the first bullet is actually the website that we have for our resource library, which is all about resources for minority aging populations, and we just have collected, I think, over 100 now different toolkits and articles and the like that really kind of focus on many different aspects of aging, but with an eye towards minority populations that I had listed earlier. You can also read the executive order if you want directly on that link. I had mentioned that we had run a summit back in June about kind of what we think as a New York State community needs to be included in this multi-sector plan. And then we wrote up those ideas in a report. So I'm happy to send that to you. And then you can, of course, email us at our general inbox, or probably it's even better, and I'll put it in the chat as well, my email. And hopefully you can tell that I feel very strongly about this topic and these topics in general. So I'm happy to continue the conversation and or answer any other questions or thoughts. So that's where we are. I'm going to stop sharing, and I put my email in there.
Yes, thank you.
Yeah, absolutely. Any other thoughts or questions in the last few minutes?
I have other things to add. I did other things in New York, but for 20 years here, I worked in the public sector in the state as a community mental health center. And, we're ahead of the game here in Hawaii and also behind the game, but there were tons of social workers and case managers. And from my experience working actually in Mount Sinai with the Black and Latin, mostly Puerto Rican people at that time, disadvantaged people, they had bags full of pills. They went from clinic to clinic. It wasn't organized. And one of the problems is that these private health insurance companies have their own social workers. So people should only have one social worker or a case manager to look at their benefits and their regular medical care, and even putting the pills in boxes, so they could see it for a week or a month and stuff like that. So going with them to appointments, if they didn't have somebody to go with them, what the doctor said and all that kind of stuff. So it seemed to me that case management really helped. These were people with serious mental illness, but it kept them going. And I would say that the key to healthy aging is to be involved in some activity that you really care about, whether it's mental in a book club, or physical, or spiritual, or artistic, whatever it is, just some activity that you care about.
Yep, totally. I'm with you there. All right. Well, lovely chatting with you all. Stay posted on news as the multi-sector plan for aging develops, and feel free to contact me.
Thank you so much for joining us.
Thank you very much for doing
Yeah,
this.
you're very welcome. So nice to meet you all.
It was nice to meet all of you. Yes, it really was. And
All right. Thank you. Bye-bye.
one of these days, okay.
We'll catch up in Central Park.
Okay,
Bye-bye.
thank you.
Thank you. Thank you, everyone, for joining us tonight.